Okay.
All right, Ed. You want to start?
Good evening. I'm Edward Lynn, and I am pleased to be the moderator for tonight's town hall meeting. I know many of you that I recognize from previous meetings, and tonight we have a little bit different information to provide you. As you know, the world of COVID is evolving, faster than we can keep it up. With our knowledge, and we're trying to disseminate things as quickly as we can to the audience. We have a very distinguished group tonight, Dr. Vishnu Chandi, who is well known to you from Metro Infectious Disease. Dr. Vijay Yeldandi is one of our guest speakers, who is a clinical professor at the University of Illinois in Chicago and very active in their global health program. And he will be sharing with you his very recent experiences in India, where the pandemic has reached crisis proportions. And Dr. Kate Mullane from the University of Chicago will round out the presentations for this evening. I'm going to ask you to enter any questions you have into the chat. We're not going to address those until the end of the talk, and we'll try to pick out ones and group them together to make an appropriate and manageable answer to all of your inquiries. So with that, I'd like to introduce Dr. Chandi, who also is from the Chicago Medical Society's COVID task force, where he chairs the group that's been extraordinarily active last year in trying to deal with this crisis. Dr. Chandi, thank you for addressing us this evening.
Thank you, Ed. Thank you for the kind introduction. Thank you, everyone. Today is somewhat of a seminal day. We have kids being vaccinated, and then we also have the CDC with the new mask mandates. And I wanted to go over what the Chicagoland area is doing, what Illinois is doing, and what the U.S. what we're doing internationally. Next slide. So this is the heat map that you see for Chicago, and you can see from our prior heat maps, it's like whack-a-mole. The red that you see around O'Hare, which is out here, is calmed down a little bit, but now we're getting new areas of red in the south and along the lakefront. And the lakeshore site, which was red before, has kind of calmed down. So this is the kind of pattern that you expect to see with COVID-19 in the future, where you get one area that's hot and then the rates fall down. But our rates, next slide, our rates have stayed stable right around 4%, 4.8, 4.5, 4.1%. The 7-day rolling average stays about 435 cases. It's decreased from the prior 510-day cases. Deaths, thankfully, have remained stable. 6 deaths and 7 deaths, still alive, but it's better than what it was. The reason why it isn't all, clear blue skies is the variants of concern now. And we're going to talk a little bit about variants of concern after with Dr. Mullane, because this is going to be the crux of the issue, along with social distancing, masking. So we've seen B117 strain, which has now become the more aggressive, more predominant strain, but the P1 strain is increasing. And the P1 strain is the one that has caused devastation in Brazil. We've also identified 351, 427, and 429, which were detected in California. Next slide. And concurrent to that, you can see what's happening with the vaccination. The vaccination rates have fallen dramatically. The 7-day rolling average of people getting first dose vaccines have fallen. If you've been at the United Center parking lot where they're giving vaccines, it's basically crickets. People are not running out there to get vaccines anymore. And so we're going to have to pull out all the stops to get folks vaccinated. Next slide. And the percentage of people vaccinated, this is 1 dose, okay? 1 dose, so it makes everyone look good. Over 65, good. People over 18, you're around 60%. And then all of the folks are just under 50%. Next slide. And then you can see where the Illinois hotspots are. They've changed now. Peoria, Central Illinois, the places where coverage is less, you're seeing higher rates of incidence of infection. And this is what's going to be throughout the United States. Next slide. And then you can see the test positivity rate for the 7-day rolling average is 4.1%. It's below the threshold of 8%, but it's staying dead solid steady around 4%. Next slide. The mortality rate is not really changed that much over the last month or so. It stayed relatively flat, it's increasing but not significant. Next slide. And the percentage of 65 and over Illinois-wise that have gotten vaccinated is pretty strong. 80% of the folks over 65 have now been vaccinated. Next slide. With 1 dose. 16 plus, you're getting near 60%. Next slide. And then the daily reported cases in Illinois getting vaccines have dropped. And you have lots of surplus vaccines, and there's lots of vaccine in downstate that's not being used. We're actually seeing vaccine here being not used. Next slide. Fully vaccinated is the issue. You know, people talk about these first doses, but only 36% have been fully vaccinated of a population of 12,741,000. So we have a first world problem here. Next slide. And this is an interesting thing that this is all from IDPH website. You can see that the vaccine breakthrough that they reported, which we don't quite understand. They say 183 people have been hospitalized due to COVID-19 after being fully vaccinated, and then 56 people have died, but they don't give you the actual breakdown of what they died of. Was it truly COVID or not? And this we need more clarity on. Next slide. And then nationwide, this is from the New York Times of how each state is doing. Illinois, with 1 dose, we've reported is doing pretty well, but you can also see California, Washington, the Northeast is doing well. The problem of concern is the South. And if you get to the next slide, fully vaccinated. 2 doses, which is Indiana, the South, West Virginia, Utah, Wyoming, Idaho. That's an issue. We are not getting high doses of vaccine rates for both doses. And this is going to cause issues with variants of concern. Next slide. And leading up to Dr. Yeldandi's talk here, the world cases are increasing steadily. And this is being driven by mostly South Asia, but also by the Americas with Argentina, Brazil, Chile. Next slide. And if you look at COVID cases per 100,000 population from April 27th to May 19th, you can see most of the world, the India, you can see the Middle East, and South America, Argentina, Uruguay. Last time we presented this, it was deep black red, and now you're seeing Argentina also at the same state. Canada, our neighbor to the north, our well-behaved neighbor to the north is not behaving so well. And they're having a higher rates of COVID. Next slide. And then this is a strain that is now a variant of concern. It was a variant of interest a week ago, and the WHO 2 nights ago with their meeting have made it a variant of concern. What does that mean? It means that this variant now has been identified as more transmissible, it has been less vaccine susceptible, and increased pathogenicity. It doesn't mean it's not vaccine susceptible, but not as susceptible as the prior slides. And this is one of the strains that's causing significant problems in India. And we're going to get some more information on this as this goes on, and you can see the mutations that are out there. Next slide. And these are the territories where this 617 is spread. It is in the United States. It's all over the world. Next slide. And the highest number of new deaths, you can see this looks like Mount Everest here. And most of these cases are coming from India with 26,820 new deaths reported. Indonesia, which is a very populous country, Bangladesh. And so this may be a reporting thing where the countries aren't reporting, but the death rates are just skyrocketing. Next slide. I think that'll do it. And this is the new news out there that the vaccine has been approved by Pfizer for 12 and above. And so kids are getting vaccinated. Hesitancy is higher in the rural areas. And we as a medical society are going to have outreach to vulnerable communities and have increased access points and contact points where people will come and get vaccinated. Next slide. So Dr. Yeldandi, who is my mentor, a friend, and colleague, who I've worked with for now 3 decades of my life, has seen this first wave of the pandemic in India, where he's situated most of the time, and he's seen the second wave. So he's going to talk about his recent experience. He just returned a few days ago from India. So Dr. Yeldandi, you're on.
Thank you. Can we have the next slide, please? Next slide, please. So basically, I wanted to talk about a little bit about the myths and realities. So compared to last year, I'm seeing an enormous increase in the number of patients that I am personally taking care of. And unlike last year, when I would have 1 or 2 people in a family get infected, this time what I'm seeing is an entire family is coming down with COVID at the same time. So the question is, who's left as a caregiver? And everybody knows of a friend, a neighbor, or a family member who's either become critically ill or has actually passed away. So much larger number of symptomatic people. Last year, I saw a few infected people who were asymptomatic. This year, everybody, almost everybody is symptomatic. Very few people remain completely asymptomatic for any length of time. And also a much larger proportion of infected individuals progressing from milder to much more severe illness and much more rapidly progressing. They're telescoping. A large proportion of individuals taking very long to recover with persistent elevations of CRP in particular. So it's a very frequent recurrence of symptomatic illness a few days after stopping anti-inflammatories. So what I'm doing now is not stopping the anti-inflammatories until I'm certain that they are clinically resolved and the CRP is near normal. And I'm also seeing quite a few individuals presenting after the first dose of vaccine and even after the second dose of vaccine. A small number of people having a lot of chest syndromes, tachycardia, disabling fatigue, a lot more than I was seeing last year. And also quite a few people who seem to have been recovering or recovered. Some actually went home, and then sudden death. Now, I don't know what the cause of the sudden death is. As you know, the speculation in the literature about the exact mechanism of sudden death. These are not people who were clinically showing systolic dysfunction or had abnormal echocardiograms, and in some cases actually had a normal echocardiogram prior to death. There's an explosive increase in the demand for high resolution CT scans, despite us telling everybody that it's not really necessary for everybody. There's an explosive increase in the demand for remdesivir. And then I'm seeing an epidemic of questionable regimens: doxycycline, ivermectin, high-dose vitamin C, high-dose vitamin D, zinc, high-dose steroids, antibacterials, proton pump inhibitors. Now, to be fair, I can't blame them because the All India Institute of Medical Sciences, one of the apex medical bodies in India, and also the Indian Council for Medical Research, has put out a recommendation to give people ivermectin. I am absolutely flabbergasted, but that's the reality. There is an increase in the number of patients that I'm seeing who have abnormal lung examination, lots of rales in the lungs, and they're not necessarily hypoxic. Now, interestingly, some of the people that I've seen who have abnormal lung examination, which I did not see last year, have had a history of being treated with ivermectin and doxycycline, and they are presenting to me with persistence of symptoms. There's an absolute complete collapse of public hospitals.
What happened here? You there, Vijay? Oh. Dr. Yeldandi. Well, let's go to Dr. Mullane while we get Dr. Yeldandi back. Let's go to Katie.
Okay, can you see? Can you go on to the next slide?
Ah,
All right, you're moving too fast. All right. Okay, next slide. Next slide, please. All right, so here are the questions. How is this illness different from the previous epidemic of SARS and MERS? I think that the key issue, unlike SARS and MERS, is this virus is a whole lot more contagious. And unlike SARS and MERS, it gets to a much higher viral load, much earlier illness. And why did the epidemic grow so much out of control? I think the key thing to understand is the lack of adequate ventilation and physical distancing not being practiced in India. Indian houses are small. There are lots of people in one house. So it's very easy to spread the infection very quickly from one person to the other person. The other thing that I think is an issue is that we all underestimated the R0. And reality is that the R0 is probably much higher than any one of us thought about. And this is something that has allowed the epidemic to spread. And even though there was an initial flattening of the epidemic curve due to the lockdown, the lifting of the lockdown simply allowed the epidemic to grow wild, particularly because there were large congregations of people for religious festivals and also the elections. Now, this is a major problem in India because in India, it is very difficult to persuade people to physically distance, persuade people not to congregate in large numbers of 10, 50 people or hundreds and thousands of people. The other big problem we have in India is the lack of infrastructure in public health, the lack of ability to make early diagnosis and start people early treatment and give people oxygen. So I think this is an issue, and this structural problems that we have in India with the culture out there, as well as the lack of infrastructure, is what I think puts India at risk for not even being able to control this epidemic or pandemic, but in the future, there may be more exactly like this. Next slide, please. So next slide. Now, the thing that I always like to think about is my own career previously as somebody who worked in antimicrobial development. And the way we did antimicrobial development is we put together preclinical laboratory evidence, we put together clinical observation, and then we did a controlled clinical trial. And the thing that is most important is if we wanted to get a license for any antimicrobial, we had to prove clinical efficacy with a robust data set and the correct inference, not the small trials that we are seeing. And unfortunately, we are seeing a lot of small trials. Now, what is important to understand is with COVID-19, 90% of the people get better on their own. It's only 10% of the people who really probably need help with some kind of medication. Therefore, you do need a large clinical trial that has the ability to demonstrate that more than 95% of the people will benefit with your regimen. That really translates into the kinds of very large clinical trials that the recovery trials represent. Anything smaller than that, I don't think carries credibility. Next. Next. So what is very important to understand is why do we have all of this? Was this predictable? Was this all understood? Yes. Manfred Eigen in the late 80s said viruses are quasi-species, which means that they will develop into populations of incredible genetic diversity. And therefore, if you couple viral quasi-species with the kind of transmission dynamics that we are seeing in COVID-19, it should be no surprise that you will evolve populations which have a higher transmissibility and whether or not these populations with a higher transmissibility are more virulent is something that we cannot predict or control, because the viruses that are multiplying, any pathogens that keep on multiplying, are agnostic about what it does to the host. Next slide, please. So the importance of understanding this is that in that entire universe of quasi-species, you're going to have many, many, many characteristics of a viral population, both in terms of transmissibility and perhaps even in terms. So it becomes very, very important that along with vaccine, ensure physical distancing, masking, adequate ventilation, clean hands to reduce transmission. Next slide. So this is what happened in India. Look at the curve. It starts going up. There is a linear increase, but then there is an inflection point, and then you have an explosive increase. Now, you could predict all of that by simply looking at the R0 and looking at what we would call a logistic map equation. Next slide. This is what a logistic map would look like, and look at the R0. As the R0 goes keeping going up, you see that the curve becomes steeper and steeper and goes into an exponential phase. Next slide. So this is clearly what happened to the epidemic. Now, what is very difficult for me to explain to people is a network of infection. You know, things get transmitted from patient to worker. Next slide, please. So really what we need to think about is the 6 degrees of separation, because some of the people that we look at who are transmitting infection from one to the other are asymptomatic. They cannot be detected, yet they can transmit. Next slide. And we knew all of this from our previous work on contact tracing from the SARS epidemic in Singapore. And as you can see, although there are some people who transmit, very few other individuals get infected because of their transmission, there clearly are super spreaders, and enormous amount of increases occur if you have super spreaders. Now, obviously, if you introduce this into a very large congregation, as we saw recently in India, you know, in very crowded urban centers, even before there were crowded election campaign events or large religious gatherings, simply the population density with the lack of ventilation is a recipe for massive increases in transmission. Next slide. And this is about the same thing that shows pretty much the same thing, the effect of super spreaders. Next slide. And the other thing is that we took a long time to understand and acknowledge that, you know, airborne transmission does occur. It may occur less frequently, but it does occur if you combine any degree of airborne transmission with extremely poor ventilation and very high population densities congregating together. It's a recipe for massive transmission. Next slide. So one of the things that we also glossed over is the fact that in COVID-19 in particular, it is very important to understand the pathophysiology. The pathophysiology really revolves around the inflammasome NLRP3, which is what is killing people. So an antiviral alone will not work. And this is a fact that we glossed over and everybody glossed over. So as infectious disease people, we are always thinking about antimicrobial strategies. So we wasted a lot of time and energy chasing antivirals. Hydroxychloroquine is a great example. We thought it was an antiviral. It was not. Not only was it not an antiviral, it was also a very poor anti-inflammatory. Next slide. See, this is the key thing that we need to understand. Controlling the problems with COVID and the clinical manifestations of COVID really means controlling NLRP3 and controlling macrophage. Next slide. Next slide, please. So here's a very nice slide where Vandenberg and colleagues suggested that those people who cannot control a runaway NLRP3 reaction are the people with the highest mortality. Okay, as opposed to people who can control NLRP3, have a strong regulatory capacity to control NLRP3, will actually develop both a adaptive immunity with antibody and cell-mediated immunity and recover. Next slide. Next slide. And the sickest people that we've been seeing are those people who have runaway macrophage activation syndromes. And unless we have the ability to cool down these macrophages, people die. Next slide. Next slide, please. The other thing that, previous slide, please. The other thing that we also took a long time to understand is that COVID-19 causes a vasculitis. It probably infects the endothelial cells. There is a lot of inflammation. Again, the same things. NLRP3 is a key factor here, but also there are other agents like bradykinin, for example, that are responsible for a lot of leakage of intravascular material into the extravascular space. And that in and of itself will cause a lot of trouble. Next slide. Now, what is very interesting is why are the majority of people who are infected with COVID-19 not sick? Why are only 10% of the people getting sick? I think that a lot of humans are a little bit like bats. So why are coronaviruses not lethal for bats? Next slide. The key is understanding the biology of the virus infection. And one of the things that coronavirus does in particular, after it enters the cell, a reaction mediated by viroporin E3 causes a lot of release of NLRP3 mediated inflammation. And in bats, interestingly, there is a dampened NLRP3 mediated inflammation, and therefore bats tolerate all of these viruses very, very well. And maybe this was also an explanation for why a lot of humans don't have trouble, because they don't activate their NLRP3 as much and do not get as much macrophage activation. Whereas the unfortunate ones who get symptomatic and really very, very sick, we have a lot of trouble controlling their NLRP3. And this is particularly true, I see, and a lot of my patients, those people who are symptomatic for longer and longer periods of time, and those people who are destined to eventually need oxygenation are those people who have very high CRPs and also very high ferritins. So those are the people that I tend to treat with anti-inflammatories, and in particular dexamethasone and anticoagulants until their CRP has normalized, their D-dimer has normalized. And adopting that strategy, I have kept a lot of patients from needing hospitalization and oxygen therapy. Next slide, please. So really, what do we need to do? We need to prevent. What do we need to do to prevent COVID-19 from spreading even more and more? I think that the key thing is getting good information out. Good information means that we should resist the temptation of seducing people with all sorts of nostrums. And I would put ivermectin and doxycycline in that class, just like we did with hydroxychloroquine. It is very, very important that people understand that it is important to look at oximetry if somebody is getting hypoxic. The one agent that we have shown efficacy with, which is dexamethasone and anticoagulation, is the one that people should be using. That in and of itself will save a lot of people from going into the hospital. And that is what my personal experience has been. I have kept 95% of my patients out of the hospital, even those patients who have had very high ferritins, very high CRPs, and very high D-dimers, because they have gone on to dexamethasone earlier and they have avoided the need for oxygenation. Very few of my patients have needed to go on to oxygen therapy or hospitalization. The other thing that is of paramount importance is to promote vaccine acceptance. Even in India, although there are a lot more people willing to take the vaccine than vaccine is available for, we still do have people, including physicians, some of my own colleagues, who refuse to take the vaccine. The other issue is persuading Indians that physical distancing is really, really, really important, because that's the only way you can assure adequate ventilation. And masks are an adjunct, not a replacement for physical distancing and adequate ventilation. Next slide, please. So the other part, I think, is to quickly identify and then trace people. Now, what is happening in India is not everybody gets tested immediately. Some people are tested days after they've been symptomatic, and they assume that since the RT-PCR or antigen test is negative, that they are not infected. That's been a problem. Also, what's been happening is that a lot of people don't understand that even though the RT-PCR is negative because of the testing window issue, when they are symptomatic, they need to look at the oximetry and the inflammatory markers to guide therapy. And I've had a lot of people fall into that category. By the time they've come to me, they've been quite sick. And by history, I know that they were probably infected a week or 2 weeks before they came to me. Next slide, please. The other thing is treating. I think that it is important, particularly in a place like India, is to identify people early on, get them onto anti-inflammatories early on, identify people using oximetry who will benefit from dexamethasone and anticoagulation. At the current time, I am not convinced that any antiviral that we have currently in our armamentarium is really proven to be of great benefit. Now, if in the future we come across agents that have much better antiviral activity, I think that might help. But clearly right now, the only evidence that I am comfortable using is early institution of anti-inflammatories, particularly early institution of dexamethasone and anticoagulation as a way to prevent the need for oxygenation and hospitalization. Next slide, please. The other thing is, I think people need to be monitored for long-term post-acute sequelae of SARS-CoV-2. We're seeing a lot of people getting diabetes. We're seeing a lot of people getting into trouble with superimposed opportunistic infections, particularly in India. What is getting a lot of press nowadays is mucormycosis. I personally think that COVID in and of itself is profoundly immunosuppressive. As we all know, the NK cells die, the CD4 cells die, and we are seeing reactivation. I've personally seen 2 people with tuberculosis reactivated post-COVID. We are seeing aspergillosis post-COVID. We are seeing mucormycosis post-COVID. We are seeing pneumocystis. It's a personal prejudice of mine that some of these people have had treatment with very high dose steroids and or tocilizumab, and that may be an additional risk factor for a higher risk for aspergillosis or mucormycosis. Next slide, please. So I think in people do have vasculitis and they have prolonged viral shedding, particularly if they're immunocompromised. I think that some of these people who have a lot of sequelae of COVID And what I'm seeing in particular is a lot of chest syndromes, which what sounds like possibly thromboembolic phenomena. They have very high D dimers, and they have needed colchicine and anticoagulation to control their chest pain, which is pleuritic in nature, and also bring down their D dimers with anticoagulation. So I think it would be very helpful for us to follow people with CRP at the very least, which is a marker for persistent vasculitis. If I had the money, I would like to look at factor 8 and 1 milligram factor antigen levels, which we know go up a great deal in people who have persistent vasculitis. The other thing that we are seeing a lot is a lot of tachycardia, a lot of profound fatigue, and also neurologic symptoms. Eyes, ears, post-acute sequelae, not the acute ones, which, as you know, in acute COVID, we are seeing, 30, 40% of them having neurologic problems as part of their presentation, particularly ageusia or dysgeusia and anosmia being very, very common. Next slide, please. So I think what we need to do is arm a lot of community outreach workers with masks, hand sanitizers, oximeters, dexamethasone, and an anticoagulant. And if each one of these workers can just go out and look for signs and symptoms of COVID, look at oxygen saturation to decide whether we are seeing in India in particular is the incredible social and socioeconomic impact of COVID-19, particularly when entire families are coming down with symptomatic COVID at the same time. And this, I think, will have a much greater impact, long-lasting impact in India as compared to the Western world, because the social safety net in India simply does not exist. The population is a whole lot more vulnerable to the long-term socioeconomic impacts of COVID-19. Next slide, please. What we are doing at Medicity, which is a hospital about 40 kilometers outside of Hyderabad, which is a not-for-profit institution. Next slide, please. As building a small unit where we can give people oxygen, dexamethasone, anticoagulation. And it costs us about $200 a day. This compares to the private hospitals in town charging about $2,000 a day. So this way, we've at least been able to save a few people the consequences of socioeconomic impacts of this devastating illness. We are now trying to expand the number of beds that we can use to treat people with COVID-19. So at the bare minimum, they get oxygenation.
No, we lost him. Ed, I think we lost Dr. Yeldandi. Did you want to go to?
Yeah, I'm thinking that maybe we should go on to Dr. Mullane's presentation, and hopefully Dr. Yeldandi will be able to join us for the QA.
Kate?
You have to unmute, Kate.
Okay. Next slide, please. So I think the biggest issue that we're seeing in India and the areas where COVID is just taking off is the variants. And the variants of concern primarily in India and in Brazil are that there are multiple variants in each viral genome. So we're seeing the EEC or the E44 mutation in them, where we have a virus that is much more infectious, that binds easier to the ACE2 receptor site, and that has reduced neutralization from plasma from those who've previously had a COVID. And that would be with the initial variant that we had, the D614G, which is different than what was in Wuhan in the first place. So in India, the three lineages of B1617 that are present, number one has both the L452 mutation and the E484 mutation. The B16172 has the L452 mutation, and then the B1613 also has the two mutations in the receptor binding domain. But there's also more data coming out about the N-terminal domain deletions that essentially help the virus develop mutations. And so there's the H69V70, which actually allows escape mutations in the receptor binding domain to occur. And it increases the fitness of the virus. So many times when a virus mutates, it is a terminal mutation and it dies off. But with these deletions, the viruses tend to be much more fit. And then we also have a deletion Y1, deletion Y144 and L18F, and that also reduces the susceptibility of these viruses to previous neutralizing antibodies. Next slide, please. So just looking in the United States, we see that the number of variants is increasing markedly. And just in the 2-week periods, we see B117 going from 59% to 66%. And as well, we're seeing more and more of the P1 variant and the B1526 variants occurring in the US. And so certainly our concern is going to be, do our vaccines hold up against these variants? Next slide, please. So we're missing one slide that that I'm sorry didn't go in. If you look back on the mutation and variants of concerns, 2 slides back. So under variants of concern, in Illinois, at the last check, we had 44% B117. We had 7.7% B1315, which is the South African variant. We had almost 15% P1, which is kind of frightening. And the California aggressive virus, we had 11%. And then of other variants of concern, we had 26% overall. So in Chicago and in Illinois, we have every single high-risk variant that's out there. So sorry, go ahead to the proportion slide. Thank you. So when we look at proportions of viruses in the US, certainly the areas that are higher travel or higher cities are going to have much more incidences of the variants of concern. And we see that certainly in Chicago. Next slide, please. So how well do these the vaccines that we have work against the variants? So thus far, we know that there is protection from severe infection and death for all the vaccines in all settings. But for prevention of asymptomatic spread and for mild to moderate disease, it's much more variable. And the issue of the AstraZeneca vaccine purporting at 67% efficacy is something that I think is important to discuss. So next slide, please. So when AstraZeneca reported their studies, they had 4 separate studies that were ongoing. The initial studies that were published in Lancet did not include the patients from South Africa. And so they were purporting 67%, not including those patients. So in South Africa, they had a small proportion of patients. They only had about 1,500 patients. And the overall vaccine efficacy in their patients ended up being 21%. But when they separated out the time of when people were infected, knowing that in South Africa, approximately the end of October was when the variant presented itself, the B.1.351 variant came on board. In those patients, when they're separated out, the vaccine efficacy was only 10%. So averaging the 4 studies, yes, it's 67%. But when you look at the areas where there is high risk of a variant that's going to be resistant, only 10%. And that's the reason that Dr. Fauci was angry with them. And that's the reason that South Africa has refused to take the vaccine. Next slide, please. So how do we check to see if the vaccines are going to have efficacy? Well, in the South African study, they took the 42% participants who had COVID, 41 of them, they were able to successfully sequence the virus. And in 39 of those 41, they were variant. And again, in those strains, it was 10.4% efficacy. In the other strains, before October 31st, it was much higher at 75% efficacy. And then pooling the data showed the 67% efficacy. And you can see that on the pseudovirus neutralization antibody is looking at a virus that is carrying the mutations and then seeing if they can, we can neutralize them with the current antibodies on the vaccines. And for the UK, did pretty well, less well when we look at the South African variant. And when we look at our original virus, the titers of antibodies that were needed are far less than what we would see with efficacy against the variants. Next slide, please. So we've seen some of these slides or iterations of them. We're doing pretty well in the United States at vaccinating people. So in the US, we have 0.3 billion people, but when you look at places like India, there's 1.3 billion people. Africa has 1.3 billion people. China has billions of people as well, 1.44 billion people. And so looking at trying to vaccinate those large groups of people with economies that aren't as happy as ours is a very difficult feat. And so it's certainly going to be up to us to protect ourselves as well as the rest of the world, to vaccinate everyone in the world, not just those in high economic countries. Next slide, please. So this is the total number of vaccines that have been administered. China, we sort of don't really know exactly what their data is, but they purport that they have given 3.54 million doses of vaccine, which ends up about 25% of their population has been vaccinated. In the US, we've given 2.64 million doses, and in India, actually 1.76 million doses, which seems like a lot, but because the population is so great, it's a very low percentage of people that get the vaccine so far. Next slide, please. So what vaccines are being used? Still, Oxford AstraZeneca is being used more than any other vaccine, followed by Pfizer's, Moderna's, and then the Chinese are sending their vaccines to the Middle East and to Brazil. We know that they're not quite as effective against the variants, but they're the ones that are being supplied to them. Next slide, please. So we need to get to herd immunity, and how do we do that, and what level do we need? So we're looking at probably needing a level above 80% in order to have herd immunity occur. And that's going to cost a lot. So right now with Pfizer, it's $19.50 a dose. Moderna's $15 a dose. Novavax, that's coming on board hopefully soon, is $16 a dose. versus the one and done Johnson & Johnson, which is $10 a dose, and AstraZeneca, which is $4 a dose. Now, the other concern is going to be, as soon as the federal funding is gone, how much are these vaccines going to cost? And post-pandemic, it's expected that the Pfizer vaccine will be $150 to $200 a dose. And so it will certainly be out of the reach of poor countries. Next slide, please. So the next question comes up, willingness to vaccinate, which is sort of our favorite topic right now, trying to get people to get vaccinated. And so when we look in the United States, we see that we have a pretty good proportion of people who've had at least one dose of vaccine. But we have a large proportion of people who are unvaccinated. They're willing to get the vaccine, but they need to get in gear and get it. We have a lot of people as well who are uncertain about getting the vaccine. And then we have about 25% of our population who are unwilling to get the vaccine. And so that's the group that we really need to work on in the future. I think that might be my last slide. Next slide. That's it.
Thank you, Katie,
Sure.
for the excellent presentation. And you can see the issue currently is Dr. Yeldandi still there? Vijay, are you there?
Yeah.
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 So yeah, a couple of
Can you hear
questions
me?
about
Yeah, can you hear me?
rural. Yeah, there was a couple of questions about rural versus urban India with pediatric populations from Dr. Vidya Sagar there. The question was comment on rural versus urbans.
So right now, the problem that we are seeing is, although initially the epidemic was almost exclusively urban, there has been substantial spread to the rural areas, but there are no facilities to take care of people in the rural areas, none whatsoever. No testing, not even oximetry, and simple anti-inflammatories and oxygen. So it's really become a very, very, very big problem. Now, fortunately, in terms of children getting COVID, I have not seen a lot of children becoming symptom.
Vijay has a bad internet connection.
He's been laboring with that, unfortunately, throughout his talk. I know we've tried different things.
Yeah, there've been there's another question on colchicine as an anti-inflammatory in the course of
is pretty steep.
Vijay, there's a question on
Benefit, but in the recovery trials, the hospitalized patients, colchicine was not of great benefit. So clearly, it seems to work in some people in very early mild illness, but I'm seeing a lot of people progress to needing dexamethasone, even on colchicine.
Very good. Katie, I have one question about the vaccines. Are the new, with the AstraZeneca vaccine, are they, with the new variants, are there trials out there to change it to include the variants, including the South African, the E484K variant? And what do we do with these new variants that pop up, like what's going on in India right now?
So right now, for the mRNA vaccines, it's pretty easy to be able to make new vaccines that will cover the variants. And those are actually being studied right now. Moderna has theirs ongoing at the NIH, and Pfizer is certainly working on it. And again, the elegance of that platform is that you can do that. It's very nimble. And the question is going to be, do we just give people another booster dose to make sure that their titers are high? Do we give them a combination vaccine, or do we need to? Are the drug companies going to have both their initial vaccine and booster doses? Is it going to be mixed together? Because certainly we don't know any of those answers at this point in time. For AstraZeneca and for J&J, I think it'll take a little bit longer for them to be able to get the structures together in a more rapid fashion, but I'm sure that they will follow through as well. I don't know where they are in their research.
And then there are several questions about breakthrough infections after both doses of vaccine, Katie. Can you comment on that? Because we're all seeing it as infectious disease doctors. I just saw 2 people today.
Well, we do know that, remember, the vaccine is only 95% effective. After 6 months, we're seeing it at 91% effective. But as I kind of put in the blog, I think we really need to know more about those patients who are breaking through. Are they immunocompromised? We know when people are getting Rituxan, they're not even going to make any antibodies. And other people on all the other disease modifying agents, from psoriasis to rheumatoid arthritis to Crohn's disease, we don't really know how those are going to be affected. Pfizer is starting a study on that, and we're hoping to be a site for that study. So we'll be looking for people who haven't been vaccinated, who have CLL or are in renal failure or got a transplant, to look and see if they are responding and how their lymphocytes react, in vitro to the vaccines, to try to figure out, can we make things better? And unfortunately, as Robin Avery has published a couple of papers, with 1 dose of vaccine, not so very good, maybe 20% in the liver transplant and kidney transplant population. And then in patients who've gotten a 2nd dose, lucky if we see 40% of them developing some antibodies. So I think part of it is our highly immunocompromised patient population. And we know as well that they're a concern because they're the ones that breed the mutant viruses. So we have to figure out some way to be able to get those people protected from the virus, and to protect us from the problems that occur in those patients.
Today, with the masking mandates being changed, what would you recommend for your immunocompromised hosts, whether they're older, whether they've gotten chemotherapy, whether they've been on, the folks that you expect in general practice for masking? Because now you're going to have a rush of people not wanting to mask when they go in and eat.
Yeah, well, certainly it's personal opinion, but I still tell people that they need to wear a mask. And I still tell people, if they're going to go out to eat, that they should go at the off hours when the restaurants are quiet. Better if they can eat outside than inside, now that we're getting to warmer weather, and still need to social distance. I don't think it should change at all for them.
And with these new variants coming in, do you think the risk of spread, we're seeing is increased in these areas? Is the R naught? Vijay, Dr. Yeldandi there pointed out the R naught in India being high. And so this concept of reproductive rate is not a static rate. It's actually a fluid rate depending on density of population. So if you look at the city of Chicago, where would you expect increase in transmission versus, Lincoln, Illinois?
Well, any place that there's going to be crowds and people not wearing masks. So, worrying about things like the venues of concerts, worrying about venues of the beach, if, people are out there, although it is a little bit safer because of the sunshine and the air circulation. But I think any closed areas where there's going to be big populations, weddings, et cetera, are going to be a concern.
So I see Dr. Grassi there, who's used to crowd surfing on these in the concerts. So some of the folks who are going to Lollapalooza and those areas, I think you'd advise your kids and your grandkids and to be really careful out there. Is that a reasonable statement, Katie?
Well, I think so. Of course, there's no data to say that, but I just think intuitively we should be. I think, when we look at SARS-1 versus this epidemic, with SARS-1, the World Health Organization said shut down all airports. They were shut down. That certainly helped to, keep the number of people dying from it to 8,000, even though it was in 26 countries. But there's a couple other things that are harder with this virus, in that people can carry it asymptomatically, where checking people's temperatures early on is worthless. So looking for syndromes in people who are exposed to COVID is not helpful at all, because they may carry it for 5, 7, 10 days before they even develop symptoms, and they're spreading it at that time, which is not the same as it was with SARS-1, where you could, early on check people's temperatures. So I think we're just, I hate to be the person who's saying, Chicken Little here, we have to be careful, but I think we do. I think we have to continue being careful, and we have to realize we don't know everything about this virus, and we don't know how it's going to change, and we should be smart up front.
So it's 7 o'clock, and I'd like to thank Dr. Mullane as well as Dr. Yeldandi for their time, and everyone for attending. I hope this is useful, and we will be topical for the next town hall also. Thank you very much for attending tonight, and have a good night. It's a nice day outside, so enjoy what's left of it. Thank you.